Good morning, everyone. Welcome to our EHE Regional Learning Collaborative session on innovative linkage to care approaches. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIP. For anyone who's new to the Learning Collaborative, our purpose is to facilitate knowledge sharing and support collective and collaborative action across California's 8 EHE Phase 1 counties to help accomplish our shared EHE goals. And of course, we also welcome folks from outside these 8 counties to join the sessions and learn together with us. So thank you all for joining this morning. In the chat, you should see an option to send a message to all panelists and attendees. Please use that option to introduce yourself to everyone by sharing your name, your affiliation, and your location. Next slide, please. Today's session will feature 3 great presentations covering effective strategies for linking and engaging community members in HIV care. Our first presenter will have to leave us for another important commitment this morning following her presentation, so we'll take a few questions right after she presents. And we'll then continue with our second and third presentations and spend the last 20 minutes or so on panel discussion and open Q&A. As always, please feel free to submit questions at any time during the session using the Q&A function on your Zoom control panel. We'll use the Q&A function to collect and respond to questions throughout the session and during the live Q&A at the end. We'll also keep the chat function open in case you'd like to share comments or resources with the group at any time. I also want to note that we are recording the session and we'll post the recording and slides on our EHE Regional Response webpage within the next week. So now I'm happy to introduce Erin Antunes, Lynx Coordinator at the San Francisco Department of Public Health. Thanks for joining us, Erin.
Good morning. Thank you so much, Elena. Thank you, everybody, for joining and spending some time this morning on the EHE Regional Learning Collaborative webinar. I am Erin Antunes, and I work at the San Francisco Department of Public Health. I am the coordinator for the Lynx program here. And today I'll be talking to you more about what our program is and what we do. I'm very grateful to be on this presenting with other colleagues in the state and excited to hear about their work. Sadly, I have another commitment for an offsite team meeting that starts at 11, so I will be dropping off after this, but I will follow up with any questions if I don't get a chance to answer them after. One other caveat is that these slides are a little rough around the edges, so just bear with me. I didn't have a lot of time to prepare them. But yeah, I'm going to jump into them. Let me see if I can share my screen now and get the slides going. Okay, is that working? Okay, wonderful. Okay, so let's make sure that they are advancing to. So when we were practicing, of course, this worked. Okay, there we go. All right, so today I'm going to be talking about the Lynx program here, who we are, what we do, and how do we work with people living with HIV and those who are also diagnosed with STIs, and how do we address challenges and barriers with linkage to care and navigation. So again, I'm seated in San Francisco at the health department, and we have a program called Lynx. Lynx stands for the Linkage, Integration, Navigation, and Comprehensive Services Program. I am the original navigator for the Lynx program. Maybe about 11 years ago, I was recruited from doing another project and in the health department doing outreach, and my medical director was like, hey, can you come over and try to work on this new CDC funded project to improve retention and care? So we originally started the program with the focus to address what we were seeing as like disparities in retention. And then we actually, over the years, we've had a more integrated approach to what Lynx is, and we've expanded the program to be a larger team, not just of navigators working with people living with HIV who are out of care, but also including a team of disease intervention specialists working to prevent and reduce the incidence of HIV and STIs, including syphilis, chlamydia, gonorrhea, trich, a bunch of other STIs. And we have this integrated approach to the care and treatment of these STIs and a status neutral approach where, a DIS or a navigator can be working with somebody who is HIV negative and working with them on making sure they get adequate syphilis treatment or make sure they have their gonorrhea treated, and also referring them to on-site PrEP at our clinic. I work at the STI clinic here in San Francisco. That's the only health department STI clinic here in the city. And we also, have this unique role as the providers in the health department to offer partner services to people who are diagnosed with HIV and syphilis. So this is like one of our advertisement cards where you can really see that there's across the board, we have like this messaging around, where we can connect you to sexual health services. We can work with you if you're living with HIV and need help linking to care. We can offer you PrEP if you need PrEP or any testing. We can offer you services, immediate services to STI testing. So that is what the Lynx team is. And this is just some photos. This is obviously all pre-pandemic, closely gathered together. We have a diverse team here, and this is some shots of the faces of folks. And we often try to show pictures when we're presenting about the program to demystify who are the DIS that are calling you. So these are some of the wonderful folks that have been on our team, and some current employees too. So our goals for the Lynx program are to provide the sexual health services. We also provide sexual health coaching. We have been all trained in the last year on this kind of robust model through the California Prevention Training Center to provide the sexual health coaching, which is very motivational interviewing based and kind of strengths-based positive sexual messaging, and trying to kind of reformat the idea that as DIS and navigators, we can be providing this comprehensive sexual health service instead of kind of taking the approach of grilling people about their partners and having it be a negative experience. Our other goals include ensuring treatment and linkage to care for people who are diagnosed with HIV and other STIs, ensuring rapid HIV start, and we have a citywide rapid goal to have everyone who's newly diagnosed to be linked to care and started HIV medications within 5 days of their diagnosis. We have a very robust team across the city of people who worked on the San Francisco Getting to Zero committee, and it's very interdisciplinary, and we have a lot of providers and social workers and nurse managers and case managers who have all worked on this goal to be able to offer these rapid services. And we try to have the one door hopefully will be the right door for folks. And we have these one-pager guides that you can find on the San Francisco Getting to Zero website that the navigators and folks across the city use, that are called the HIV rapid options. And it's a list broken down by providers, their provider contact information, and the type of insurance that they take to really help triage and ensure that we are really able to confidently say to somebody who's newly diagnosed, we're going to, our goal is to try to help offer you rapid today or within the next few days, regardless of your insurance status. And we also offer rapid restarts and navigation to those rapid restarts for folks who are navigation patients who have been out of care. And we also have the goal to address people's barriers to care. Often we are, we do these intake interviews with folks to ask people who are out of care what they need, what have been their barriers, and we have relationships with the navigation patients over the 3-month plus time to spend to address those barriers. We also have the goal to improve the viral load suppression rates, especially where there are disparities, and I'll show some data later, and you could also consult with our San Francisco Department of Public Health Surveillance and Epidemiology website, and there's tons of data. We have an HIV Annual Report that comes out every August for the previous year that highlights some of the the successes and challenges and disparities in our people living with HIV. So one thing that I like to talk about when we're talking about our health department role as DIS is to say, what does a DIS do? So many of you may be familiar with the DIS role. Some folks are less familiar. So we always like to say that DIS wear many hats. And one of the hats some of the hats are laid out here. So one of them is like the detective hat, like to find people to offer them treatment or offer them partner services. Sometimes a big part of the job is trying to figure out, using all of the data systems and culling through the medical record to find where somebody stays if they don't have a address for people experiencing homelessness. The detective work is a big part of the job. They provide education and have a role as a teacher. Also, sometimes people will come out of doing a partner services interview and say, wow, I feel like I just was this person's therapist, and they confided in me, and I've had DIS call me from the field and be like, wow, I just met with this woman, and she was basically crying for an hour, and she was telling me all these feelings about her diagnosis and about her partners and about her past. And so people sometimes provide this lay therapist experience. Also, we like to say that the staff and the team are public health warriors. I think we all have had the experience in the last almost 2 years with COVID of feeling like, showing up every day at work. And our team has really not been remote. We have 1 day remote, but we still have been coming in every day. We have not, we have been on the front lines and providing sexual health services throughout the pandemic. And then also we have this idea that DIS have to wear the hat of a customer service expert to be able to figure out what's the sell, like what is in it for a patient or a client to talk to a DIS. Somebody can decline or refuse any of the services that we offer, but what is the sell? Why would somebody want to engage? Why would somebody want to talk to somebody from the health department about being newly diagnosed or being out of care? So really trying to be able to be harm reduction approach to figure out, meet people where they're at, and to provide services in a way that feels like the client is getting what they need. I also would like to talk about what our navigators do. And so we can let you know that out of care HIV patients are referred to us via a variety of sources. So we can get referrals directly from providers. They'll just send us secure emails and say, haven't seen my patient in the last 6 months. I'm really worried about them. They had a detectable viral load 9 months ago. They're not answering calls anymore. This is what we've already tried to do. So we take those provider referrals. We also will take panel manager, like a clinic nurse manager will sometimes email us a list and say, here's our panel of people who haven't been in the last year or 6 months. And these are the folks that have detectable viral loads. They haven't been responsive to us. We've already tried mail and text and calls. Please, can you help us, Lynx? So we take referrals that way. We also take data to care referrals or referrals right from surveillance lists, which I will mention a little later more in detail. The navigators then work to locate patients. That's some of the Where's Waldo detective work. And then located patients are offered the navigation services, and then the enrolled patients are provided assistance to re-engage in care. And that the services can, really range from, offering Lyft rides, offering escorts, going to somebody's house and bringing them in a Lyft to an appointment, or taking the bus with them, or walking to the appointment. They can walk with them to the pharmacy. They can help triage the benefits if they lost their benefits and they had private Kaiser insurance and they now are Medi-Cal eligible because they lost their job, and helping them get Medi-Cal, Kaiser-based Medi-Cal. Or, they're doing all of these different kind of things to help address, the barrier is insurance, or the barrier is, the person stopped taking their meds because they weren't having access to food, or this person is telling me that they're experiencing a lot of poverty factors, and they don't have food, they don't have a place to stay, they're experiencing homelessness. So really trying to connect them to the right service, in addition to bringing them into their primary care where they can access primary physical care, labs, medication, doctor visit, but also they can be connected to mental health and social workers right there that can also help assess if they have other needs, especially related to substance use and mental health care. People often ask, well, how do you prioritize? There's a lot of people who are out of care. How do you decide who you work with? So we do have some eligibility criteria that I'll share, which are, we really do have a high priority for people who are newly diagnosed and who have missed even one primary care appointment, because there is data showing that people just do have poor health outcomes if they start missing HIV primary care appointments right immediately after their diagnosis. We also will prioritize people who are hospitalized with a detectable viral load. This is often a great time where we will get a call from or an email from the hospital team called the FAST team at Ward 86 in San Francisco General. And they'll say, we have a patient who was out of care and they have just reappeared at the hospital with an OI or something going on, and can you send a navigator out to meet them? It's often like the captive audience. They're going to be here for a couple of days. So the navigator can go and meet them and do some visits in the hospital. And that's a great way to establish the relationship and the rapport and make a plan for when they get out of the hospital to engage in primary care. And they're often restarted on HIV medications immediately when they're in the hospital. We also will prioritize people who have a detectable viral load who have not been seen in 4 or more months, especially people with high viral loads over 100,000. So that's like, we often get those provider referrals or provider panel emails asking us to work a list of patients like this. And then we also prioritize people with a very low CD4 and a history of poor medication adherence. So we'll often take referrals from folks like that. And these folks sometimes are also the people who are hospitalized. So our strategy is really data driven, and we do work with our surveillance partners. It's another unique part about being in the health department, is that we can offer, we have this data, we have the access to look at the electronic HIV AIDS registry by sitting at the health department and all of the confidentiality agreements that we have with our surveillance partners. We do offer partner services, or what we've become more familiar with in the COVID terms in the last 2 years is contact tracing, where it's a evidence-based intervention to try to identify people. So you talk to the newly diagnosed person about who they've been having sex with or who their sexual or substance use sharing partners are, if they have anybody that they care about that they want to make sure that gets tested, if they want to do self-disclosure and try to bring them in themselves, or if they want the DAS to try to offer, contact the person confidentially to offer HIV screening and sexual health counseling, sexual health services to their partners. And then also, again, alluding to the data to care, that we use I already mentioned this, we already use our partners in surveillance to provide us data to care lists of where they'll query the HIV registry to look at anybody with a detectable viral load within a certain amount of time. And then the navigators will work those lists by trying to contact those people and offer them short-term case management and support to help them re-enter medical care and restart medication. And then finally, our team does do some detailing work where we support clinicians and CBO partners to increase access to the testing and services. So we will, a lot of our CBO partners in the health department, if they are testing in the field, they'll call us for information in the history about patients. And then also we're able to, sitting at City Clinic at the STI clinic here, if they have a new diagnosis who doesn't have insurance and meets the eligibility criteria to be started and offered HIV care here at City Clinic, we have the open door for people to access the rapid HIV starts here, or be able to triage and refer them appropriately to the right clinic to get rapid. And then, so just thinking about the time, okay, I'll spend just a few minutes talking about our successes and challenges. So, we do have some successes over the last few years. I have been in my role as the coordinator for the last 5 years. We have just seen a really consistent decline in new HIV diagnoses over the last 10 plus years. And it has continued. Even we just had, I'll share a slide, but it continued in 2020. We had the annual surveillance report that came out in August of 2021, showed that in 2020 there were only 131 new HIV diagnoses in San Francisco. And that's versus 5 years prior in 2015, there were 295. We have had a high rate of linkage to care and linkage to rapid. 90% of new diagnoses last year in 2020 entered care within 1 month with the evidence of a viral load. And we have a high rate of viral load suppression with 77% of newly diagnosed people. We only measured from January to June 2020 because of the time delay in monitoring this with viral loads and surveillance. But we have evidence that 77% of new diagnoses from those first 6 months of 2020 achieved viral load suppression within 6 months of their diagnosis. So this is, the top of this slide got cut off from the snipping tool, but this is taken from the SFDP HIV Annual Report. You can find that easily by Googling it, or I could put the info in the chat or ask me later. But this basically shows you the orange bars are the total people living with HIV in San Francisco over from 2006 to 2020. And then the green line shows the number of new diagnoses. So as I was mentioning, that we've seen a pretty consistent decline in the last 10 years, going down to 131 last year. And then we have seen a fairly stable number of deaths for people who have been living with HIV. And that bar, we are anticipating in 2021 that we are going to see an uptick here, because we already saw in the first half of 2021 that we already had a higher rate of diagnosis. So I think due to the pandemic and other factors, there may have been less testing, as I'm sure some of you also have experienced. We are anticipating our first increase, but we will have to see how that data comes out, and it won't be released again until August of 2022. But unfortunately, we are seeing that. I'll jump. That's a good transition to jump into some of our challenges later. But this is also one other slide I wanted to show from the surveillance report that really shows that we have had, if you're looking at the yellow bar is the 2020 diagnoses, we continue to have high rates of linkage to care and rapid within 1 month of diagnosis. Again, that was 92% of people diagnosed last year were linked to care quickly. Retention in care has remained in the low 70%, and then the viral load suppression rate, as I mentioned before, was 77%. It's a decrease from our 2019 rate of 84%. So this is something that we are concerned with, but this was only from the first 6 months of the year. So more will be revealed. We are anticipating that it is logical. We did have some significant challenges with meeting people with COVID, and we had a lot of changes in our approaches to ensuring field safety for our staff, and to reach people who are especially people who are experiencing homelessness, being moved from encampments to SIP hotels, and had some significant challenges reaching folks who are marginalized. But I did want to share that. And then, so this leads us into some of the challenges we've experienced. We've had some recent staffing challenges. I'm not sure if this will be reflected with other presenters, but we've had, staff just having high rates of burnout. There's been a lot of trauma from COVID and all of the different experiences that people have had in their personal lives and family lives outside of work. Also, we've had this trend of increasing complexity of people living with HIV. So like 10 years ago, when I started as the first navigator, a lot of people that I was assigned, when I found them and talked to them, knocked on their door, got them on the phone, often they reported that they were out of care because they lost their insurance or they didn't know how to navigate it. This is like pre-Obamacare, like the Medi-Cal expansion. And a lot of my work used to be about navigating insurance, and that really has changed now that a lot of people we've seen big increases in people experiencing homelessness with active substance use, polysubstance use, meth use, fentanyl use. I don't think this is unique to San Francisco. I think this is a trend that we're seeing statewide and beyond. An increasing complexity in dual and triple diagnosed patients with mental health. We've also, San Francisco, if you look at our surveillance report, I'm not going to spend a lot of time focusing on this, but we really have had over the years of, the 30, 40 years of the HIV epidemic here, we've had a very MSM, gay male predominant driven HIV kind of picture in our city. And that has really changed in the last few years, where we have seen increases in cis and trans women being diagnosed with HIV. We've seen some parallels with increases in syphilis that are happening statewide, increase in female syphilis, increase in congenital syphilis, some intersections with people experiencing homelessness, and also with active substance use and survival sex, and just increases that seem to be, having a changing picture in San Francisco. I think last year there was like a 16% increase in the number of females who were cisgender females that were diagnosed in San Francisco. And so just trying to find creative ways to reach women, and cis women and trans women, and how to engage people in different ways that are person-centered, person-first, harm reduction-based, non-judgmental, low barrier, low access. And we've tried to do that with addressing, having strong partnerships. So we have this citywide network of the DPH clinics that provide HIV primary care. We have a wonderful team called the FAST team based out of San Francisco General that consists of nurse and social worker and a doctor, and they can do really wonderful wraparound services and offer that rapid support. We also have great CBO partners that do testing, and they do field outreach, and they connect with us very easily by calling and texting and say, hey, we have somebody, are they on your radar? Can you look up to see their care history? It's difficult to get a clear story of their picture. So we have a lot of communication with the CBO partners. We have, as I mentioned earlier, Getting to Zero. We have different committees, and myself and other representatives from the Lynx team have participated in the RAPID committee, the Retention and Reengagement committee, and now there's a new People Experiencing Homelessness committee, and we're working on new policies and protocols to address what we're seeing in the changes in our city's epidemic. We also collaborate with long-term case management and intensive case management programs and social workers. So the Navigators have a role where they are working with people who are out of care, to work with them for 3 months to try to give them the extra support, escorts, the calls, the reminders, the home visits, the pharmacy pickups, the bringing meds to people, the giving people socks, giving people food, helping people connect to the services that they need. And we really say we want to work with you for the next few months. We want to find your team of people that you're going to be able to work with long term. We also have been just trying to get more input from staff and patients to help prioritize during this time where we have had staff attrition. We've had people leave for different reasons, for in their family life or with the vaccine mandate. We've had several other staff that have not returned to work yet. And so it's been difficult to try to figure out how to continue to work when we have less staff. So yeah, I'm actually leaving to go to a meeting where we're having a follow-up meeting with our team, just to say, what do you all think is going to work right now? What can we do to address your needs and concerns? And what are you seeing on the ground as a frontline worker to try to help us prioritize, how to best serve people living with HIV and people who are diagnosed with STIs? How can we improve? We also have found that it's really important to hire staff from the community. We have, our team is about 90% people of color, especially led by Black and Latinx staff. We also have transgender and gender nonconforming staff have been a huge asset. We have a lot of Spanish speakers. We'd love to have more Spanish speakers on our team, because we know in San Francisco, we just have we've had an increase in the last few years of Spanish speakers diagnosed with HIV. And so, yeah, I think something that we've seen that's really important is to hire staff from the communities that we serve, and people. We also have people on our team who are living with HIV themselves and have provided a lot of input and improvement to our messaging and the comprehensive sexual health approach that, you know, having that input from people living with HIV has been key. And also now we are really in this chapter where we're trying to figure out how to address the wellness of staff, how to get support from the directors of our program to be able to provide more rest and respite days, and you know, kind of how to incorporate more retreats and more you know, meetings where lunch is provided, or you know, outdoor, getting out of the office and meeting outdoors. So we've been trying to think creatively, generating ideas with the team, because you know, a huge factor of this job is to be able to be tenacious, to be able to wear all those hats and to be flexible. But also to be resilient. You know, this is a very, you know, can be very intensive work, and just trying to find ways to, you know, trying to find ways to support the wellness of our staff. We have had for the last few years, the Navigators have a clinical therapist, a supervision group that they do bi-monthly. And then we also have, right before the pandemic, we had contracted with the Harm Reduction Therapy Center to offer everyone on staff once a month can have a private therapy, or as we call it, clinical supervision, or one-on-one, to get support as a member of our team, to be able to debrief about cases or patients or difficult situations at work, interpersonal stuff. And I think those are resources that we've tried to provide to the team to be able to increase wellness and resilience. So those are my slides right now. I wanted to just thank and appreciate everybody on our team. This is a list of the folks that are our current staff members of GIS and Navigators, and this is my contact information. I'm happy to take questions, comments, thoughts.
Great. Well, thank you so much, Erin. I really appreciate you sharing the awesome Lynx program with us this morning. We did have a couple of questions come in for you, and I know you have to jump off soon, so I just want to take a moment here and see if we can get through these questions. Sure. The first question was, what are qualifications for Navigators on your team? So are they paraprofessionals, et cetera?
Thanks. Yeah, that's a great question. So we have two ways that we hire Navigators. One is through city civil service positions and their health worker level positions, and then we also have for more soft funded, grant funded positions, we hire through Haluna Health. So we have basically we have pay equity. We have the same pay, starting pay for both ways people are hired, and the job, I think we do request that people are paraprofessionals, so there's no licensing needed. We have, I think, a desired qualification is a bachelor's degree. It can be substituted for, I think, some amount of like two years of experience. I can send a job description if people are interested, of how we've posted both through the city and through Haluna Health for those. But it's basically like experience working with the community, working with people living with HIV, or providing some sort of sexual health services in the community for usually 1 to 2 years. Sometimes we also have qualifications about language. We have several positions set aside that are designated to must be Spanish speaking. We also do have some positions where we request that people be able to maintain jail clearance. So that is, yeah, those are some of the basic qualifications.
Thank you so much. Yeah, and if I'm sure folks would be very interested, if you're willing to share kind of what you look for overall. I can send that information out after the session. I also wanted to get to one other question and then maybe follow up with you afterwards if folks have additional questions for Erin. So this question is, what are some tips you may have for doing outreach at community events?
Oh, outreach at community events. Okay, so I think it's always great to have people from the community. So say it's a community event for you know, we have like, I'm just thinking in San Francisco, we have a lot of street fairs that are like for queer men, gay men, leather men, you know, so there's all these like different types of street fairs. So I think sometimes we've partnered with our community health equity and promotion branch partners when they'll say, hey, does anybody want to volunteer? So sometimes it's like self-selecting if somebody identifies and says, oh, I'm already going to the Folsom Street Fair, I'd love to volunteer. So one tip would be like asking, you know, for volunteers and people from the community, in the community that are already excited to participate and be part of outreach. I mean, that's like one thing is like the like special events. Our team doesn't do so much of that. Our main focus is like the people that were assigned because they were just diagnosed with HIV or syphilis. So my tips around this is like, part of the hiring is like, really during the hiring interview is presenting people with scenarios of like, this is like real live scenarios of like, how would you handle these types of things? So during the interview, they start to get a sense of like, oh, this is like a very street-based, field-based position where I could be going into encampments, I could go to SROs, I could go to shelters, I could go to the SIP hotels. We also, you know, so kind of one is interviewing and asking and explaining before somebody's hired about what the role entails. And then it's like, you know, just working in the community. So I think like we have a very small part of the role at Lynx is doing community events, but I think most of my experiences really are just around outreach in the community. And it's like, you know, being prepared. We have a standard work or a protocol about field-based safety where it's like tips about what to wear and like what not to wear. And like everybody has a work cell phone and you have your personal phone. Like best practice is not to have both phones out and be texting when you're walking through Civic Center. And, you know, if you can check out a locking backpack, and you can, you know, you must send a text to your supervisor and say, I'm going to these 3 places today. And, you know, follow up with your supervisor when you're done with the visits to let them know that you've completed the visits. If you're going to be taking Lyft, these are the best practices about how to send a Lyft for a patient. If you've had a patient that has escalated in a Lyft before, consider taking a taxi or taking the Muni. So we have like all these different things that we've laid out because we've had these experiences of working in the field over the years. We also always recommend that people, like, you know, wear their badge and have like interactions that are friendly and professional but confidential with front desk staff and support services staff, and, you know, the like kind of the professional coaching stuff that I kind of really enjoy to do as a supervisor, about like being able to say, oh, I was a navigator for 5 years, and, you know, as part of the training, you'd be like, this is one time I was riding in a taxi and the taxi driver and the patient got in a fight, and this is what happened. Like, how would you handle that? So a lot of our stuff is like, you know, trying to prepare in advance because we have these protocols based off of real people's experiences, and sometimes things still go wrong. We've had people have their phones stolen or have their bags stolen, or, you know, be verbally assaulted, or, you know, having some traumatic things happen in the field. And then we've also have a bunch of steps that we've prepared for like how to debrief when you have an escalated incident in the field, and how to call for help. And if you want to process or if you don't want to process, we have a bunch of stuff that have like we've written out and tried to prepare, and still things happen that we haven't prepared for, and that we really just, you know, try to have an open door and have awareness as supervisors and as teammates of where everybody is at a time, to try to keep people safe, because safety really is like the top priority. And then COVID added like a whole bunch of extra layers around like PPE and what to bring and what to do and how to do a field screening if people are symptomatic, and not to get in the lift if somebody's saying they have a symptom. You can, you know, so we added a bunch of new stuff about field safety with COVID. But those are some of a few of my tips for doing outreach in the community. I do have 5 more minutes or you can jump to the next person.
Thank you so much. Yeah, well, I think this was really great. Thank you, Erin. And I think we will need to move to the next presentation, but if others have questions for Erin, feel free to continue entering them in the Q&A. I'll pass them along to her after the session. And then Erin, again, you know, you mentioned several really great resources. I know many folks on the line would love to see, you know, anything that you're you're willing and able to share. So feel free to just send those along to me, and I can pass them along to all of our participants as well. And thank you again for joining us.
Thank you all. Thanks. Have a great day. Appreciate it.
You too. All right, so now I'd like to introduce our next presenters. Joining us from DAP Health, Guillermo Ramos, Early Intervention Manager, and April Cruz, Diagnostic Testing and Outreach Manager. Good morning, Guillermo and April.
Good morning, everybody.
Good morning. Sorry, my computer was slow. Let's get our slide up. Let's see. Are we seeing it here?
Yes,
There.
looks good. And if you just put it in slideshow mode, I think you'll be all ready to go.
Okay. 1 second. Sorry, my computer's running very slow this morning. I'm not sure quite why.
Oh, no worries. No worries. If you go to the slideshow tab up along the top.
Sorry.
So, oh, no worries.
Where is it? No.
Above that, so animations, and then slideshow is next to animations. There we go. And then from that menu, on the left-hand side of that menu, you should see from beginning, and it should go right into slideshow mode for you.
Perfect. There we go.
Perfect. Great.
All right. As you said, I'm April Cruz. I'm the Senior Programs Manager here in Community Health at DAP. And my colleague, Guillermo Ramos, is our Early Intervention Manager. So we believe very much so in education as part of a linkage to care. So with COVID, before COVID, we used to go into schools and recovery centers and do all of our presentations. We would even have people come into our facility here. We would do mini presentations. But since COVID, we have had to rethink on how do we get education in regards to HIV, STIs, Hep C out into the community. And so we have developed ways to do it through Zoom. And so that way we could still present our education and really reach the community. We've had certain forums that we've presented, much like how we have our meeting today, where the community can join us and we can discuss our education on those items. We are also very much involved with our recovery centers and homeless shelters. We've currently partnered up with Coachella Valley Rescue Mission, which is a homeless shelter. They have a new program in which they are actually going to various homeless encampments throughout Coachella Valley. And we've teamed up with them by taking our mobile clinic with us. And we provide HIV testing as well as STI testing right out of our clinic. Everything's free for them. And it's really allowed us to reach our homeless population in throughout the county because they no longer have to come to our facility. We are meeting them where they're at. For our recovery centers, we do something very similar where we're taking our STI mobile clinic to them. If anybody comes back with a positive STI test, we are able to link them up with our Orange Clinic, which is our sexual wellness clinic, and provide them treatment out of our clinic by either setting them up with a ride here, or we can make an arrangement with their facility and they're able to transport their clients to us. And so we've kind of found ways to really connect with different community partners rather than trying to just go out basically like cold calling in the community, and really find where our community partners are already working and ways for us to link together and really help the community be able to have access to treatment and care. We've also, thanks to COVID, found new ways to help the community. There are several people that are still not quite comfortable leaving their homes, going to an event or just large public areas. And so we came up with these self-HIV test kits. We have them, sometimes we'll have different, what I call pop-up events, and where we just set up a little table with some information, and they can pick up a home test kit or a self-test kit, and they can do it in their own private space. It's a 20-minute oral swab. We follow up with one of our educators. We'll call them, discuss how their test went, if they had any questions. They go over the pamphlets that we also give them. And then if anybody does come back preliminary positive, we're able to link them up to one of our early interventionists staff members here. And then we could proceed with follow-up testing and so forth. We also have a hotline number that they are able to call. So we have bus ads, there's some radio ads we've done, just giving out the information so anybody can access them. We also have them on, I want to say Grindr links, so different apps where people, it just kind of scrolls across the bottom, you know, if they're interested in HIV self-test kit, they can contact this number, they could go online, order it, we ship it to them. Everything's absolutely free and confidential. So just finding new innovative ways for us to reach our community, because the community can't always come to us, and so we have to find ways to reach them. This is our mobile testing clinic that we have been using. We went from orange to blue, as you can see. And right now we are offering free STI testing as well as HIV and Hep C testing. Soon we'll be including the STI treatment on our mobile clinic as well. We're currently going through some training and staffing, much like other organizations with COVID and like the previous presenter mentioned with burnout. So we've gone through some staffing changes, but that is definitely up on the horizon to offer treatment as well. Early next year, we will also be implementing a harm reduction program that will also operate out of our mobile clinic. Again, reaching our homeless population primarily, but also just the community in general. We've been doing a lot of work in our East Valley, which is primarily our Latino community, just because there's more of a rural area, and so they don't have as much access as we do here on Palm Springs, and more of a metropolitan type of area. And then soon we are also working on including our Rapid Start program, also out of our mobile clinic, and then our mobile prep. And then with that, we also carry track phones with us when we go out testing. So in the event that we have a client that does come back preliminary positive and they are unable to you know, contact anybody, and we can't contact them because they're homeless, or they had a phone and they're unable to pay for it, or they just don't have a way of contacting them, our EIS team has been able to provide our testing team with the track phones so that they can connect them. And Guillermo will elaborate a little bit more on that.
So as April mentioned, the EIS team will be contacted when we have a new diagnosis out in the field. But we also provide track phones for our clients here when they come meet with us at DAP Health. This was one of the ways that we kind of figured, you know, like April said, a lot of people weren't really coming to us because of the pandemic. So one way for us to, you know, go to them would be like, hey, you know, what if we help them like with cell phone, so that they could stay in contact with us we found that a lot of the barriers that many of our early intervention clients had were transportation and like communication barriers. So that's when we came up with the whole like getting them a track phone, which I have to say that it has really helped getting our clients into care, and it's also helped retain some clients as well. Although they do expire like after the 30 days, we do work with them to get them what we would say would be like an Obama phone. So while they're, while they are in the 30 days, we're working to get the phone mailed here to DAP. Like that, if they're homeless, they usually don't have addresses and they can't use the general post office box because they won't let them for whatever reason. So we just have them mail the phone out here to us, and once it's here, we call them and we swap it out. So that's one way that we came about, like to linking our clients back into care. Another would be the Rapid Start program. So like many other agencies, we are part of the Rapid Start program with UCSF. So our main goal is to link our newly diagnosed and out of care clients back into care within 7 days. So our numbers, we were going for our out of cares, we were going anywhere from 100 to 200 days trying to get them an appointment. We went down to about 5 days in getting them linked to care. And that's when the track phones come in, and they play a huge role. Like I said, a lot of them have barriers, and communication was one of the big barriers. Another thing that we kind of figured was that with the Rapid Start, it would be better if we had them seen by the same provider within 2 weeks of their appointment. And we keep them with that provider so that they could review labs and take care of any other issues. For example, STIs or anything else that may need like antibiotics or anything like that. So any immediate health needs, were addressed sooner rather than later. And then once those two appointments were completed, we also helped them schedule their third appointment with the HIV clinic. Like that, we ensured that they had no issues scheduling the appointment. And it made it easier for them to remember and to know that they had appointments scheduled already. And once they had established that care with that permanent HIV clinician, once they have that established, they could schedule telemedicine visits. Like that, it's easier for them to attend their appointments if they are homeless or if they don't have transportation. But we also provide transportation assistance. We can provide a Lyft ride or a taxi cab so that they could get to their appointments. Other ways that we have helped our clients, I would say, is just communication and showing them that we are really here for them. A lot of the times, these clients just want to know that someone is willing to help and willing to just hear them out and not judge them and provide the support that they need. Other than that, I think we pretty much all do like the same thing when it comes to linkage to care. April?
Yeah, and so we do a lot of outreach. I know previously you were asking. So we definitely partner a lot with our community. We will piggyback on events. So if our LGBTQ community has an event, we'll always offer our services, see if there's any need, not only for like the fun events, but If they're having a forum, can we be there? We'll either table, sometimes we're just doing outreach. Sometimes we're able to also include testing. We've partnered with some of our local bar areas, and they'll have like a bingo night and we'll be there. So for us, the linkage really starts from the community knowing that we're there for them, not just for the fun times, but also when it's more serious. We are there with them at their level. So we're not coming in telling them what we can provide to them, but we are coming in looking to see what they need and figure out ways that we can work together and help them break down those barriers and really get the care and access to services the best way possible. And that's kind of where we are standing currently. Like I said, next year we will be including our harm reduction program. So that will also be going out. We will have mobile rapid start. Right now it's currently just in our sexual wellness clinic, but that seems to be going really well. And being able to have that on our mobile clinic is really going to be able to help reach out to the community members that aren't necessarily in our back door or backyard, but just link them to care and then really help get everybody all the services that they need. I don't know if we were going to open up, we were opening questions at the end, correct, Lena?
Yep, that's right. So thank you both so much. I do already see a couple of questions coming in. I do want to remind everyone to please feel free to continue submitting questions to the Q&A box at any time. We will work on answering some of those questions right in the Q&A box, but we'll also save a few for the live Q&A at the end. So thank you again, Guillermo and April. And I'm delighted to now introduce our final presenters this morning, Tiana Montiel, Care Coordination Services Program Manager, and Ruben Garcia, Options Project Coordinator at APLA Health. Thank you both for joining us.
Thank you. Thank you guys for having us. Can everybody see our screen good?
Looks great.
Perfect, perfect. Good morning, everyone. My name is Tiana Monte, and I'm the program manager here at APLA Health.
Hey guys, and my name is Ruben Garcia, and I am the I'm a project coordinator right here at APLA Health.
And today we'll be telling you guys a little bit more about our innovative linkage to care strategies here at APLA Health. Our program is called Options. By the end of our presentation, we definitely hope that everyone will be able to describe or know more about our Options Linkage to Care program that we have here at APLA Health, but also be able to assess any new strategies that you guys may have to successfully increase linkage to care targeting MSM or whatever population that you serve. Also be able to identify lessons learned from our Options program and what we're doing that's innovative.
All right, guys. So in this next slide, if we can all type in the chat box what guides your work, and we're gonna be reading everything that you guys type in. So any ideas, any words that come into mind that you guys think guides your work? So we got passion, purpose, health,
equality,
love,
unity, giving back, our clients, yes, justice. I like that, Allison.
Justice and equity.
Amelia, love it.
Amelia.
Ending
the epidemic.
Yeah.
Trust.
Yeah. Big one.
Yes.
I love that. So we also put some words that are kind of common in this field: love, community, health, family, respect. Yes, yes.
All right, innovation.
So a little bit about our program here that is called Options. Options is a DHSP funded program that takes place in a non-clinical case management setting. So not your traditional clinical case management setting. Our target population is HIV positive men who have sex with men. However, we do go beyond our scope of work and provide linkage assistance to everyone in the community, regardless of sexual orientation, just as long as you're HIV positive. We conduct brief risk assessments with our clients that address both traditional and non-traditional risk behaviors. This linkage program is integrated into all of our APLA health programs. So our various programs or services that we have to offer, they're aware of our options program and quite often refer clients in need to us for assistance. Our program encourages people living with HIV to share the biomedical risk reduction strategies with their serodiscordant partners. So ensuring that serodiscordant couples are having the appropriate conversations regarding each other's health care. Sorry.
All right, guys.
I'm sorry, Ruben, it's one more about the program, and I don't know why my slides are moving kind of slow.
All right.
Oh, there we go. Okay. Okay, so I'll go ahead with this for us, Ruben.
Okay. So so next we're gonna show you guys a 1-minute video that will refresh our minds in the philosophy behind our work.
More than 1 billion Americans are living with HIV, but nearly 2/3 do not get the care they need to stay healthy. And transmissions from those not getting care account for 9 in 10 new HIV infections. Diagnosis and care can improve the lives of people with HIV and reduce the likelihood of transmitting the virus to others. 100 people who don't know they have HIV transmit the virus to nearly 7 new people each year. But that rate drops rapidly as people go through care. Every year, 100 people who have HIV under control through medication infect less than 1. But today, just 30% have the virus under control, and 50,000 people become newly infected each year. Improving the health of people living with HIV today could prevent the vast majority of new infections tomorrow.
So guys, if you guys, based on this video, we can notice that our work in linking clients to medical care plays a huge role in ending the HIV initiative. So, you know, we should all feel proud of the work we do.
So a little bit more about the options. Oh, wait. The options program is built off of the information, motivation, behavioral skills model. And in this model, we believe that the more information or education we give to our clients leads them to be motivated to make a behavior change. Motivation interviewing techniques. I know we're all so well familiar with motivation interviewing, but it plays a huge part on making sure that our linkage programs are centered around our clients. Our options program, our linkage program, builds on our provider-patient relationship. Rapport is a huge thing for us ensuring that our clients are successfully linked to care. It incorporates brief individualized discussions. All of our discussions or assessments that we conduct with our clients are based around how they feel. It's tailored around what they want to discuss. And of course, follow-up is extremely important to ensure that clients have successfully been linked to care.
All right. So with that being said, it's important to mention that over the years, the options program has been responsive to different initiatives, such as ending the HIV epidemic, in which I'm sure we all know the four main concepts, which is to diagnose all people with HIV as early as possible, treat people with HIV rapidly, prevent new HIV infections, and respond quickly to potential HIV outbreaks. All right, so in the options program, we focus in three intervention strategies that will ultimately lead us to an effective linkage to care approach. And those are client-centered approach, building strong community networks, and follow-up. So in client-centered approach, discussions are designed to meet the needs of the client. So in other words, the client leads and guides the discussions. And within that, we try to build trust by being warm, genuine, polite, and we try to make it more personal. At the same time, we also try to be flexible and accessible. So for instance, if we ever have a client that's running late, we just don't postpone the appointment. We try to work with the client's schedule because we just don't know if the client's already having a difficult time or is having any issues getting to the appointment. So that would be kind of like our client-centered approach.
I also think making time and creating a safe space is also important for our clients. So with this in mind, keep in mind, everyone, what does your cubicle look like? What does your workspace look like? Is it warming? Is it welcome to our clients?
Right.
What is it like when clients first enter the door of our buildings? Are they greeted? Are they welcomed into the building? Makes a big impression or sets the tone for what your discussion maybe with your
and this is also where we also focus in our assessment, because we feel that when we do the assessment with clients, it's really critical, because that's where you're gonna build that rapport, that personal connection with that client. You're gonna build those trust by being warm, genuine, polite. So for us, it's really critical. All right, so our next intervention strategy is building strong community networks in areas like food, housing, transportation, mental health, just to mention a few. And we also call them social determinants of health when we think of barriers that cause individuals to not seek or to become adherent to medical care. And for this reason, it's important to have connections with other social services to assist clients with those basic needs. So, so in other words, it's important to mention that our focus is linkage to care. But before we take that step, we have to take a step back and assess our other components needed before assessing medical care. And once those basic needs are met, we also try to build strong linkage networks with clinics and medical providers in order to have a smooth linkage process. And this means having at least one contact person in each clinic that will assist you quickly link clients to medical care. In other words, the options program not only builds a close relationship with clients, but with other social services programs and medical providers. Okay, so these slides also kind of like correlate with the previous slide in which we try to expand our linkage networks beyond the usual or typical services like food, housing, mental health, benefits, counseling, et cetera, et cetera. For instance, back in February and March, the options program was assisting clients getting connected to COVID testing and helping them get registered for their COVID vaccine. And this is how we were able to build rapport with our clients by going above and beyond our scope of work. And so we think that this is really important because it's going to lead us to our next intervention strategy, which is follow-up.
So I think with the options program, we've looked outside of just medical care for our clients. We're looking at the social determinants of health. That also plays a big role in knowing if our clients are going to be successful for the linkage that we provide to them. So like Ruben mentioned earlier, COVID testing has been a big thing. We want to make sure that we also successfully link our clients to other medical issues as well. In 2020, APLA Health held a flu clinic for clients as they came to pick up their groceries. So we're thinking outside of the box of just the traditional linkage to HIV medical care. Are our clients gonna actually be successful with that linkage if we don't address the other social determinants of health as well?
So follow-up, once we have link clients to medical care and they already have a setup appointment, we try to contact the client 1 week before their appointment, just as a reminder. We also do that 1 day before, just to make sure that they don't need any type of special needs service such as transportation, or just to make sure that they're going to be able to get to their appointment on time. And after their appointment, we also try to do a follow-up to just kind of like go over them. How did their appointment went? Do they have any additional questions that maybe their doctor or like someone at their medical clinic wasn't able to respond? A lot of the times, if the client feels that it would be convenient for us to join them in their first visit, we're able to go with them for their first appointment. So that's kind of like our follow-up, like trying to be connected with the client 1 week before, a day before, and after the follow-up.
What we've also done that's been innovative now, given COVID and technologies, in addition to phone calls, we are also texting our clients. That's been great a lot. We've noticed that more people are more responsive through text messages than phone calls. We definitely want to be able with follow-up to meet a client wherever they are in their follow-up of linkage, and to also check in to see if there's other needs that we should address, or barriers as well that's preventing us for successful linkage into care.
And that is really important, what you just mentioned, Tiana, because clients have actually been really, really responsive in the way we communicate with them. For the most part, a lot of our clients, I've noticed that they're more responsive to text messages than to phone calls. So, when we try to do follow-ups, that plays a huge role on this particular approach. And then financial incentive. Once the client has met their goal, we surprise them with with like an incentive. And this is something that we don't let them know because we don't want them to be focused on this incentive. It's just kind of like something that we provide them at the end as a surprise thing. So, they feel good about themselves. And it's a way to kind of like reward them for what they, for meeting their goals.
We've realized with not advertising this or promoting the incentive is that clients feel more rewarded at the end, knowing that they've gotten some form of accomplishment or recognition for completing their goal. We've been asked, hey, if there wasn't financial assistance, what could be other ideas? We've thought about certificates of completion or just something to make them feel rewarded or that they feel accomplished with number one, that they set it a goal and that they fully complete that goal. Plays a lot in clients sticking to that behavior change, should I say.
Exactly. So lessons learned, we have ambivalence. We go beyond their diagnosis. We try to build trust with both clients and providers, scheduling, flexibility, staffing, and we try to do realistic expectations with our clients.
And I think staffing plays a big important part on building rapport. It's very difficult for our clients when they see a high turnaround in staff, or they see that, I've shared my story or with one staff person. Now here I am needing to work with another person in sharing my story. It just builds rapport when our clients have that same interaction or the same face when coming or working with an individual.
And that also played a huge role when we were actually connecting clients to COVID testing and getting our clients connected to getting their COVID vaccine. A lot of the times they don't really know people at APLA unless you work with them constantly. So in that particular area, at least for the options program, they already know who to go to, or at least ask questions, where would be the appropriate place to go. So yeah, it does build like staffing. It builds like rapport with clients.
And I'm also so happy that you have on here, Ruben, to go beyond their diagnosis. People with HIV are living so much longer that we need to look beyond just their HIV issues. I have so many clients that did not expect to live this long with HIV. So many other life issues have come up. For example, a pandemic. Who could believe that they will be alive right now during a middle of a worldwide pandemic? So looking beyond their diagnosis plays a big part on ensuring, number one, that people are successfully linked, but also that rapport, you guys. That plays, at least for us in the options program, that has had our clients to continue to come back to us. Ruben is so knowledgeable in Linkage and has a very strong network of people that he can go to, but they come to him for other issues as well. Keep in mind, those social determinants of health play a very big key also in our scope of Linkage and what we do.
Exactly. All right, so last but not least, so the options program is feasible and practical intervention that is effective in the adoption of health promoting behaviors targeting people living with HIV over the course of a 30, 60, 90-day follow-up. We try to establish connections and relationships with a network of programs and agencies because we think that this is a critical, critical part of the process.
Having that strong foundation as linkage to care specialists or case managers or nurses or just anyone in this field plays a big part, because we can't just rely on ourselves to make our clients successful. The options program from year to date has successfully enrolled 154 individuals, and we've addressed your traditional risk behaviors, linkage, and your non-traditional as well. So that has been very successful, again, in focusing on what the client wants to, making it very much so client-centered. Pretty much what we have. Ruben, is there anything you wanted to add?
No, Tina, I think that's all we have, unless there are any questions for us.
Thank you, Elena.
Okay, well, wonderful. Thank you both. Thank you both so much for sharing your great strategies with us. Now I'd like to actually invite all of our panelists who are still on the line to turn back on your cameras, and we'll just have about 10 minutes here to answer additional questions that have come in. If you haven't had a chance to enter questions in the Q&A, feel free to continue doing that. We'll get to as many as we can now, and then we'll follow up on any additional questions after the session. So one question that came up quite a bit during registration, and it's also come up during the session itself, really has to do with addressing key challenges in the context of linkage to care. So many participants mentioned, they face a lot of challenges linking individuals to HIV care when those individuals maybe are dealing with a lot of different complex needs. So maybe starting with our APLA health team, what are the most common challenges you say you run into when working to link clients to care, and how do you navigate those challenges?
Right. So based on our experience, I would probably say that the top two challenges would be one, transportation. That's a given, and also substance use. I think substance use plays a huge role whether or not that client will actually be getting connected to medical services. And that is why we mentioned that sometimes we gotta take a step back and try to like assess what other needs the client is in need of. Because without that, then we're not gonna really be able to fully link that client to medical care.
I also think too, just getting a simple appointment in a timely manner is a big issue for so many of us too. You have that client right then and there. They may be at that point where today is the day I'm empowered to make that change. And if you can get them as much done in that one setting, just scheduling appointments in a timely manner for that client plays a big part when linking service to guys.
And that is why I mentioned that it's really important to have a contact person at different medical facilities, whether it's at a AHF or APLA or like the Gay and Lesbian Center. Like, you gotta make sure that you have one contact person so that you can go directly to that person and try to like schedule something. So I think that's really critical.
Thank you both so much. How about for you, April and Guillermo? What are some of the key challenges you face in linkage to care, and how do you address those challenges?
I think for the most part, they're basically the same issues as APLA. Substance abuse is like a major one here out in Palm Springs, and homelessness. So, how we deal with that? Well, we have to get to the client's level and figure out where they are at, and what's more important to them at that time. We do have a rapid start for our out of care clients. So if available, we'll schedule them that same day and get them back on medication. If the appointment is available, and number one, if the client is ready. Because we could schedule as many appointments for them as we want and we can give them everything. But as long as they have those substance abuse issues, I don't think that they're gonna, want to get into care. When it comes to homelessness, it's kind of like, I kind of think like what would be more important to me at that time, to have somewhere to sleep that night or to schedule an appointment for medication or to schedule an appointment to come see a clinician. For me, it would basically be like finding a place to sleep. Especially out here, the summers are brutal, the winters are, cold, even though we might not think it's cold out in the desert, but the winters are cold out in the desert. Summers, it gets to 120, 125. So I think meeting them where they're at is important. As I don't think there's any other way like to get them linked into care. Like, I think as they have to be ready. They have to be ready. They have to want it. They have to want to make the change for themselves, or else it's not gonna work.
Thank you so much. So I just want to highlight something that I think both teams really spoke to, which is this idea of, folks dealing with all of these different complex needs may not be in a place to prioritize linkage to HIV care over, say, finding a place to sleep for the night. And so I love, your kind of collective recognition of that and working with them to meet them where they are and, hopefully get them linked to all of their different, care needs. But potentially that means prioritizing other things first as a way to kind of deal with their most pressing needs. I want to move to one other question, which is, unfortunately, we know that many community members who are initially linked to care end up falling out of care. So what strategies have you found to be most effective for relinking community members to care who may have fallen out of care? And maybe we can start with our DAP Health team on this.
What we have found useful is, like I stated earlier, just meeting them where they're at. It's just hard. It's hard. It's hard
to find out, what caused them to fall out of care.
Yeah.
That they lost their job, or they broke up with somebody, and
like
kind of start
barriers, like the barriers that they have at that moment. Right now, we're trying to implement a program. Well, I think we started November 1st. So for our Rapid Start program, we have an LSW who will meet with the clients and kind of figure out where they're at and determine, okay, so what can we do for them to make sure that they're gonna stay linked to care, that they're gonna come to their doctor's appointments. So that's something that we, that we're piloting that with behavioral health. But it's just hard. I don't know. What do you guys at APLA, like, what do you guys think? What do you guys do? Because I found that with our linkage to care, for the most part, we're good at keeping people in care once we get them back. But once they start, using again and they start dealing with homelessness and substance abuse issues, like they fall.
Right.
So what do you guys find easy? Like, I don't know.
For us, we feel that when we do the assessment with client face-to-face, we just feel that that's a critical component of getting to know each other, building rapport with the client, and basically getting to know each other. And whenever clients just fall out of care, there could be like so many reasons. One of the things that sometimes I do seem to notice is a lot of our clients might be homeless. They lose their cell phones, and sometimes it's a little bit hard to get in contact with them. But what really helped us is the fact that we're able to build that trust, that rapport with clients, that connection. And whenever we try to communicate or get in contact with those clients, it's easier for us to actually get in touch, get in contact with them, that they will answer our text messages, that they will answer our phone calls, because we have done a connection with them since the beginning. So that's kind of like a key to us.
Okay. Yeah, we also do an acuity. Sorry, Tiana. We also do an acuity like at our first meeting with them, and that's where we get a lot of the information and figure out like, okay, so we're gonna take this route, or they're gonna need assistance with this medication because they don't have insurance and stuff like that. So yeah, we also do, but we call it acuity.
And I think as linkage to care specialists, we always have to go back to the stages of behavior change. They may be at that contemplation, pre-contemplation, and take steps back. And I think as health navigators, it's important, our linkage to care, case managers, nurses, that we always have our arms open and welcome to take them back, at any time, because a client may come back to me and Ruben forgot totally about linkage to care, but now because we built that rapport, they've come to us with their other needs or their other issues. They totally may have forgot about linkage, but hey, they built that relationship with us to still come back to us for food or for housing. And at that point, maybe we have them again to be able to try it all over again. But I'm always reminding Ruben and myself to just think about that stages of behavior change, not only with our clients, but ourselves sometimes too, you know, when we're working on that diet or, you know, trying to cut back on whatever it may be. It's very important.
And that's why we, one of our intervention strategies is a client-centered approach. You know, we focus on them, on their needs, on their basic needs, hierarchy of needs.
Thank you. I wish we had so much more time to chat with you all because you have so much good insight to share, but we are now at 11:30. So I do just want to, you know, thank all of you again, all of our amazing panelists for sharing your work and your wisdom with us today. I want to thank all of our attendees for your great participation. I know we got several questions also answered in the Q&A box, but we will follow up on any that we may not have had time for during the session itself. As usual, please look out for a follow-up email from me with relevant information from the session and a link to the evaluation form. And again, the recording and slides will be posted by early next week. So thank you all so much again and have a great day.
Right. Thank you, guys.
Thank you, guys.
Thank you.